then the patient develops angina pectoris, and if he's unlucky and he has plaque rupture, he may experience an infarction. So the whole life cycle of cardiovascular disease starts with these risk factors that induce endothelial dysfunction and eventually angina pectoris and myocardial infarction. And when it moves further, of course, you have also a heart failure and pump failure and deaths. And you may also have stroke if it occurs in the cerebrovascular circulation. Now, when we look at LDL as a major risk factor for atherosclerosis, as indicated by Rudolf Virchow's statement that it is actually induced atherosclerosis by lipids, then we can look at the blood vessel wall. Here are endothelial cells, these are the smooth muscle cells, this is the subintima. If you have too much cholesterol in blood, you have too much cholesterol in the subintima. And this cholesterol gets oxidized in atherosclerosis to form oxidized LDL. And this is a foreign body, an antigen that induces inflammation. And inflammation is driven by monocytes transmigrating into the subintima to form macrophages. And they have specific receptors, such as the SRA, the scavenger receptor A, CD36, and others that can take up oxidized LDL to form foam cell. And that is the classical yellow plaque. And of course, then there is also inflammation with cytokines such as tumor necrosis factor, interleukin, and so forth that sort of support this inflammatory chronic process. There was a Japanese Akira Endo that discovered while working with fungi in Osaka that there are substances that lower cholesterol synthesis in hepatocytes. And one substance he discovered was lovastatin. Fortunately, he never got the Nobel Prize for it. He would deserve it. Because lovastatin, as you know, lowers cholesterol. You can lower LDL cholesterol quite remarkably. And this is the summary of what has been done in the last 30 years after his seminal discovery. You can see here the event rate and here the LDL cholesterol. If you have a high cholesterol, for instance in the 4S trial, 4,444 Scandinavian patients with angina pectoris or myocardial infarction, their event rate was almost 30%, and their LDL was about 180. When they got simvastatin 40 milligrams, their event rate dropped to 18% and their LDL to 124. And in other trials, such as Lipid and CARE and Prove It, we saw the same thing. So this gives us a direct line in showing that the lower, the better. The lower your LDL, the lower your event rate. In secondary prevention, these are all patients that have heart disease, such as infarction, angina pectoris, or something similar. In primary prevention, these are subjects that come to your office and they just have a high LDL. And of course there's also a straight line, the lower the better, but the line is much flatter. So the benefits, the numbers needed to treat are much higher here than they are here, at least over a 5-year period, while if you look in the long run, it may look quite different. Now what statins do we have? We have 4 statins, pravastatin, simvastatin, rosuvastatin, and atorvastatin. The older statins are less potent than the newer ones. The newer ones, they lower LDL cholesterol in general by about 50% if you move up with the dose. Now, if you have a myocardial infarction, and here we are really in secondary prevention, if you have a myocardial infarction, you want acute treatment, you want revascularization, and this really lowers the event rate, or the mortality in this instance, substantially by about 50%. Early treatment of statin also lowers it by about 30%. So if you take revascularization and statin together, you get a huge effect. So patients should have medical prevention and, of course, an acute intervention. To prove this, the Prove It trial was done in 4,000 patients by the TUMI group, comparing pravastatin and atorvastatin 80 milligram, and they looked at death, heart attack, stroke, and revascularization at 30 days and beyond. And what they found is that all-cause deaths and major cardiovascular events over 30 months was significantly lower with aggressive lipid lowering with atorvastatin, compared to pravastatin. Pravastatin lowered LDL by about 30%, atorva by 50%. You get an additional 16% relative risk reduction in major cardiovascular events, as published in the New England in 2004. Interestingly, in the Armida trial, they could show that infarct size is actually reduced when you have early treatment with a statin. This is creatine kinase MB and troponin in a placebo group and then atorvastatin high-dose group, and you can see that infarct size, as judged by the myocyte enzymes, is significantly reduced under these conditions. Now, many colleagues have concerns about the high-dose atorvastatin or rosuvastatin. However, the safety meta-analyses published in several journals, they all show that essentially it's quite safe to have 80 milligrams prescribed to your patient with an acute coronary syndrome. However, of course, you have to check the lipids, the liver enzymes, and the CK and the total CK after 8 weeks. If they are normal, I think you can continue with the drug treatment. If liver enzymes or CK are elevated, I usually change to another product. So, besides, of course, hypercholesteremia, we also have to consider hypertension, and we'll hear another talk later on, diabetes and smoking. I just talked about myocardial infarction. What about patients that have an acute, not an acute infarction, but have chronic angina pectoris? They're at lower risk, but they also are high-risk patients. And to test this, TNT was designed, the Treat to New Targets trial. There was a similar trial, A to Z, with simvastatin 10 and 20 and 80 milligrams. But here I show you 10 and 80 milligrams of atorvastatin. And of course, if you are more aggressive with the dose, you get more LDL lowering, you get more total cholesterol lowering, more triglycerides, but no HDL. The statins are not good at HDL, they're good at LDL. The TNT trial clearly showed that 80 milligrams, a high dose of a modern statin, is more efficacious than a low dose. So absolute risk reduction was from 11% to around 8.7%. Numbers needed to treat was 45. So we do recommend that if patients have the disease, if they have coronary disease, either stable or acute, we do recommend to treat them with 80 milligrams of atorvastatin. Now the next question is, what about patients that have no atherosclerosis yet, but a major risk factor such as diabetes? And diabetes is really the cancer of the blood vessel, and so we have to be aggressive in treating it. Now, is there evidence to do so? This is the design of the CARDS trial, which was performed in around 3,000 patients with type 2 diabetes and no previous myocardial infarction or no coronary disease. It was performed in 132 sites across the UK and Ireland, and they randomized patients to either atorvastatin 10 milligrams or placebo. It was an event-driven trial, and after 5 years, they had a total of about 200 events. 127 occurred in the placebo group, 9% event rate. The event rate in the atorvastatin group is 83 events, 5.8. Highly significant, with a number needed to treat of 331. So if you have patients with diabetes, I think they should all have a statin, irrespective of their LDL, because this effect was seen both with an LDL above and below 120. There was a concern, however, about statins to be an inducer of diabetes, and this is a meta-analysis published in The Lancet on the statins and risk of incident diabetes. So these are patients that have no diabetes yet, and they watched whether or not they would develop diabetes. And in fact, what they found was that in ASCOT, but particularly in Jupiter with rosuvastatin, less so in WASCOPS with pravastatin, there was a tendency to have more diabetes in those receiving the statin compared to those who were in the placebo group. The overall risk was not very high, it was around 10%, but they concluded that statin therapy is indeed associated with a slightly increased risk to develop diabetes in those who do not have diabetes yet, but both in absolute terms and when compared to the reduction in coronary events induced by the statins, the risk is low. So you should watch, besides the liver enzymes, also blood glucose and glycosylated hemoglobin in your patients. So in diabetes, we shouldn't just look at the heart, we should also look at the kidney, because the kidney is an important target organ. Patients have kidney dysfunction, and diabetes, diabetic nephropathy is a major cause of hemodialysis. In the PLANET trial, AstraZeneca looked at rosuvastatin, 20-40 milligram, and compared it to other statins, and they randomized around 2 times 353 patients in PLANET 1 and PLANET 2. They recruited patients with diabetes, with mild hypercholesteremia, and they all were on an ACE inhibitor and ARB. And this is important when we also looked at the data on proteinuria. The primary endpoint was the change in proteinuria and the creatinine change at baseline compared to 52 weeks. And what was surprising and a bit scary was that the change in estimated GFR was actually quite pronounced. So there was an almost 7% decrease in kidney function over 1 year in those treated with rosuvastatin, but not in those with atorvastatin, which was not changed at all. And this was dose dependent. It was less in 10 and 20 milligram than in 20-40. So in diabetic patients, I don't think we should prescribe rosuvastatin because it may actually harm the kidney. And in fact, when you look at the proteinuria data that were presented by AstraZeneca to the FDA, you can see rosuvastatin, atorvastatin, simvastatin, pravastatin. And you see these 3 statins have no effect on proteinuria whatsoever. However, with rosuvastatin, there is a dose-dependent increase in proteinuria upon treatment. Probably this is related to specific effects of this compound in the tubuli of the kidney. This brings me to the question, is it good if patients are on hemodialysis to give them statin if they have renal insufficiency? And there, one of my former fellows, Christoph Wander, published in the New England Journal of Medicine in 2005, over a 6-year period, that the cumulative incidence of primary events, cardiac deaths, non-fatal MI, and fatal and non-fatal stroke was unchanged. So it appears that if you have severe kidney failure, the statins no longer work. So in the diabetics, you should give statins early on when they're still rather healthy before they end up in hemodialysis. Now let me move to another aspect, hypertension. But of course, this will be covered by the next speaker. But I just want to show one particular aspect, and that is not the hypertension treatment itself, as tested in the ASCOT study, but the question whether in patients with mild hypercholesteremia, whether it's worthwhile to treat them with a statin compared to placebo. So these are normal hypertensives with a little bit of cholesterol. 10,000 patients randomized in a double-blind manner. And this investigator-led study was performed over 3.5 years. This is the cumulative incidence of stroke, MI, and death. You can see that the overall event rate is not so high in hypertensives, it's 1% per year. But over 10 to 20 years, it adds up. And when you give them a statin, you can reduce the event rate by 36%. So hypertensives should have a statin when they are appropriately treated with their blood pressure. Now let me just show you one slide on primary prevention. The question, should we treat patients that are completely healthy yet? We have AFCAPS with lovastatin, WASCOP with pravastatin, ASCOT with atorvastatin, and we have Jupiter with rosuvastatin. These were all comers, these were high-risk patients from Scotland. These were hypertensives, I just showed you, and these were patients that had a high CRP. And if you have a high CRP, mainly metabolic syndrome, and an average LDL, then you can show that compared to placebo, indeed, you can reduce events when you give patients rosuvastatin in this particular instance. The question whether everybody should receive a statin, of course, is also a political one. It has to do with costs. And these patients, of course, have a lower risk than if you have hypertension or diabetes. Let me finish with heart failure. Again, I showed you that in patients with diabetes, if you wait long enough so they have renal failure, statins no longer work. So if you prescribe statins, you have to prescribe them early on. The question is in heart failure, if you have multiple infarcts and you have a patient that comes with heart failure, should you prescribe him a statin when he has a ventricle like this? And the question is answered by two trials, the Corona trial and the CHF trial. Both performed with rosuvastatin, and again you see no effect. So if you wait too long with your patients, the statins no longer work. If they are in renal failure or heart failure, it's too late to treat them appropriately, so one should start with the treatment early on. So I would like to finish by saying that we have lots of trials: hypertension, ASCOT, hypercholesteremia, lipid care, diabetes cards, in high CRP, Jupiter. We have important trials in patients with coronary artery disease, 4S, IDEAL, and TNT. They all show that you should be aggressively treat those patients, even more so if they have an acute coronary syndrome supported by miracle and prove it. However, if you wait too long, it no longer works. In heart failure and in renal failure, there's no effect whatsoever. However, in stroke, PROSPER, ASCOT, and SPARKLE all showed positive effects under these conditions. So if my second speaker doesn't show up, I just would like to show... Oh, he's here. He's here. Okay, good. Oh, okay. I didn't see you. Well, okay, then that's what I wanted to say, and I'm looking forward to hear you to expand on hypertension. Thank you very much indeed for it.
Thank you very much. This was a very clear lecture and review of the effect of statins on cardiovascular risk. Maybe we can have one or two questions.
Yes.
Yeah, go ahead.
Thank you, Chair. My name is Bahaz Zaid of Cairo University, Faculty of Medicine. I'm a nephrologist, I'm not a cardiologist. Yeah, so we talk about the 4D trial, we all guessed about this, and there is a post-hoc analysis that hypercholesteremic patients have benefit from using atorvastatin 20 milligrams. What about your comment about the SHARP trial?
Yes.
They have proven that simvastatin convention, simvastatin is role has been proven efficacy in dialysis patients.
Yes.
So in your comment about that?
Yes, it's a very good question. In the interest of time, I didn't show it. The SHARP trial was actually a trial where patients received, in addition to simvastatin, ezetimibe, which lowers cholesterol by about 18%. And they had, luckily enough, they had a small but significant effect. It's about 17% relative risk reduction. The event rate was not so high, and the primary endpoint was changed before the trial was finished, but it was done in a blinded fashion, so I think it's okay. So ezetimibe may have some effect, but the more severe the renal failure is, the less effect you have. So I think the lesson that we have from all these trials is that if you have patients that are at risk for renal disease or for heart failure, you should treat them before they have it. It's much more effective. There's a second trial besides the 4D trial, which with statins, that also was negative or neutral. So it is more difficult. The renal patients are actually at a big need, and we have to find ways to treat them better.
I would like to ask you